Hello, everyone, and Happy New Year. I'm Rose Gerber, COA's Director of Patient Advocacy and Education. We're very excited to start off the year with this chat series once again with the cancer policy and the year ahead, what to expect. During this conversation with Ted Okon, our Executive Director, and Nick Ferreyros, our Managing Director, we're going to gain a lot of insight on what to expect this year. As many of you know, we recently celebrated 20 years as an organization, and a lot of that time has been spent on Capitol Hill. Because COA is so well known for advocating for cancer patients and their doctors, we are now sought out as the voice for community oncology, which is a tremendous honor for us. COA is also known for acting quickly and proactively on any threats to the patient-physician relationship. And as we've learned through these chat series and through COA conferences and events, there's many threats to patient care. Both Ted and Nick will be giving us updates on the Stark Law, drug delivery, the ongoing threats from the PBM issues, which is pharmacy benefit managers. And you all may recall that in June of last year, we were all on Capitol Hill, we being physicians, doctors, physicians who are doctors, cancer patients, pharmacists, talking about PBMs. And something that you may all remember is how many PBM bills there were. So we're going to hear updates on that today. And we're also going to hear what's happening at the state level in the advocacy and policy front. And that's very active, as well as what's going on at the federal level. And this is all going to be very interesting for all of us, I'm sure, but it's particularly of interest to me, I know, is what's happening with artificial intelligence and how AI is starting to affect how patient decisions, how cancer care decisions for patients are made. So this is going to be a great start in our education for the year. Thank you, Ted and Nick, for joining us, and it's all yours.
Great. Thanks, Rose. I'm going to start off. I'm going to kick it off here and basically talk about a little bit of the landscape, some of the issues, what we can expect in the new year, and I'm going to hand it over to Nick. So I think everybody knows that it's a real challenge getting through anything through Congress right now. They're basically facing keeping the government open and funding. There's two key dates, one on the 19th of January, one on the 2nd of February. And so a lot is unfolding right now. This is a particularly difficult year because it's a major election year. So you not only have a third of the Senate, all of the House, and of course the president's up for election, that it's going to make an especially crazy year. And typically when in these major election years, you get some things done early, then there's a lull, especially obviously they go back to campaign. And then there's a lame duck, depending on who wins, who loses, in terms of getting some things done. So we've got a lot of things that are on the, on the docket here. In fact, I was on with a committee staffer earlier today, and he was asking me how things were going, and I said, I've never seen in 20 years of COA a year like 2023. When there was more going on, we were actually making more progress. I don't say that as organizational ego, just in terms of fact, than we've ever seen before. So we want to extend that in 2024. But the reality of the world is that we will be hitting sort of the gridlock of a major election year, coming up after some things get done. So let me give you an idea and cover a couple of things that we're working on, what the implications are, and what I think will happen in general with them. I'm going to really focus on something short term, and that's what I was talking with the staffer earlier today, which is this Stark Law violation. This came out of the blue. This was something that in September of 2021, CMS published a frequently asked questions document, and they basically said that during the public health emergency, there was a waiver in place that basically stopped it from being a Stark Law violation if a medical practice sent out a drug via mail, courier, UPS, FedEx, or even allowed a patient representative to come in to pick up the drugs. And basically what they said, it's a Stark violation that if the patient if anything but the patient coming in to pick up their drugs happens. This is really crazy because if you don't know much about Stark Law, Stark is the law. Pete Stark basically championed it, so it's his law. He's actually dead now, out of the Congress, obviously. But basically what the law says is a physician cannot refer to him or herself. There are exceptions to that, like the idea that you can give chemotherapy in a practice, injectable chemotherapy. But by and large, the whole idea was no one knew that if you were going to simply dispense an oral cancer drug and deliver it to a patient or have a patient family member come in and pick it up, that it would be a stark violation. You're not referring anything to yourself. Now, in the absurd example, if a physician's practice had a UPS franchise and they referred all of these drugs to be sent out for UPS through their franchise, you could possibly say that that was a stark violation. But even then, that would be pretty crazy. So the problem with this is something that impedes patients getting their oral cancer drugs. And it's very serious, especially not only in rural areas, but in areas or in situations where the patient simply doesn't have the transportation or is too sick to come in. So that being said, just so you know, we are all over this. There's a bill in the House, there's a bill in the Senate, and we are working with other organizations in other areas of medicine to get the leadership behind this. COA is actually in litigation with HHS and CMS. This is so serious. So we're making this a top priority to get passed somehow, some way, somewhere in the first half of the year. That's a big challenge, but we are doing everything possible, that and sort of the legal effort behind this. So I think the prospects are pretty good. We already have a lot of co-sponsors on the House bill. The Senate bill was just introduced, and we will be actually on the Hill. We'll have about 40 people on the Hill, just a small little compact team next Thursday, actually trying to drive up some co-sponsors in the Senate and add some sponsors in the House. So I wanted to say that's something very immediate, but it's a very serious thing because it impedes patients from getting their drugs. When I talk about PBMs, you can go down the list of basically PBMs and how they obstruct patients from getting their drugs, where they say that, no, you have to get them through our mail order and you have delays, deliveries, where they're basically taking the money in terms of copay, what's called copay accumulators. There are a number of PBM issues that they not only get in the way of patients getting their drugs, but they fuel drug prices. This is what's so amazing about the PBM issue is right before the pandemic, I would say you would hardly get one Democrat who would talk about PBMs. The problem was it was all pharmaceutical companies and drug costs and everything else. Now there is a bipartisan, there are over 20, close to 25 bills. They're pushing bills to trying to get some PBM legislation pushed into this extension of the keeping the government open, which I don't think will happen. I was on a call earlier today about that. But the fact of the matter is, what you should know when we look into the crystal ball, what we're trying to do here, I think it's a very good chance that you're going to see more federal legislation coming out on PBMs. Nick's going to address in a minute some of the state efforts that's happening on the PBMs. So PBMs is a very real thing, and it's a very bipartisan issue. Another really thorny issue is, those of you who remember years ago, we used to watch at the end of the year, had to sort of overcome these cuts from the sustainable growth rate in terms of Medicare reimbursement that the commercial payers follow. Well, now we've switched it over to what's called macro. I'm not going to get in the middle of that, but we're in the same crazy situation. Physician reimbursement is broken, and it's broken in terms of Medicare, and it is broken in terms of commercial payers that follow off of Medicare. Why is that a patient issue? Because you're seeing the drying up of physicians who accept Medicare. You're seeing the drying up of physicians in general. You're not only seeing sort of acquisition by hospitals in terms of that, and we'll touch upon that in a minute, but you're basically seeing physicians that want to retire. I mean, the oncology population is an older population, and some oncologists that I know have just thrown up their hands and said, I'm out of here. It's not worth it anymore. Constantly fighting for what I want to give the patient, what's optimal to them, as opposed to the insurance. And in fact, I'm not going to go into it because we really haven't seen it yet wholesale, but we have seen an example of where an insurer is using AI to sort of determine who gets treated with what. And the idea of having the computer decide versus the physician in concert with the patient is really a very scary thought. So I just want to tell you that even though we talk about physician reimbursement and people say, well, I don't care, my physician, they make a lot of money as it is. The bottom line is this is an access issue, and it's turning up into a very real access issue, so that it's something that's really important when we talk about these MD payment issues. The other thing that I just want to touch upon is, and by the way, they are in these bills trying to get something done, but I think we have to fundamentally overhaul how physicians are getting paid, and it's a big issue because you want to keep up access. You want to have access to physicians, not only primary care physicians, but specialists like oncologists. So once again, I think you see a lot of movement and a lot of reality on a bipartisan basis here that we've got to get something done. The problem with a lot of these things that we want to do is it costs more. So you have to find basically something that will increase revenue to the federal government that can be used to offset to the cost of, for example, increasing and doing something different with physician pay. I think one of the interesting things is there's been big, obviously, in years past, emphasis on value and quality and different mechanisms of pay. A lot of those have largely stalled. We've seen some of those stall, especially in oncology. The last thing I want to do, and I'm going to hand this over to Nick, is just say site of service. Once again, 4 or 5 years ago, you would really not see, you would see a number of especially physicians in the Congress, pushing for the idea that the same procedure, the same drug administered, whatever that may be, the cost should be the same in the hospital setting as in the physician office setting, especially the outpatient hospital setting, because we've seen instances of where an oncology practice is acquired, a patient is in between, let's say, their second and third cycle, and they come back and they get the bill, and now because the hospital's billing, they get a facility fee. Everything is greatly increased. And, I'm not damning the hospitals as much as saying the reality of the world is today, there is now a big push and there is legislation to basically create more site payment parity. And I think you're going to see more of that as well, too. So if I look into the crystal ball, not only this year and beyond, that another issue that's going to get tackled is related to the site of care, and even the idea that you've heard us talk about 340B, something happening on 340B. So I'm going to stop there. I'm going to hand it over to Nick. He's going to touch upon the site of service, go into some of the state issues, and we'll leave some time to answer any questions. Nick?
Thanks, Ted. So as Ted mentioned, site of service is becoming a really big issue. Somewhat expected, as the pressure's been building for the last few years. I think a lot of people recognize there is a very important role in our country for hospitals and healthcare delivered through our hospitals, but the cost that is associated with that is tremendous, both in terms of tax benefits. Most hospitals in the United States are what are known, on paper as nonprofit hospitals, so they're not paying taxes on everything from their real estate holdings to their profits. And in many cities and counties, hospitals are some of the largest landowners and largest employers. So there's a lot of money there that these supposed nonprofit hospitals are making and keeping. And there's a good argument to be made for examining where that money is going and that flow. But in addition to that, that nonprofit status gets them access to something you may have heard about before called the 340B program. 340B is a government discount program where hospitals and other sort of eligible entities that are nonprofit are supposed to get discounts on the drugs that they purchase and give to patients in the outpatient setting, so that they can then use those savings to provide better care to the uninsured or underinsured. Unfortunately, this program has grown enormously because if you're ever given an opportunity to get a discount on your largest resource, and then you can then go resell for full price or even a marked up price, you're going to take it. And so lots of hospitals in this country have taken advantage of the 340B program. and are not necessarily delivering upon the charity care or uninsured care that they should be doing. And there have been plenty of examples of that. There's a wonderful New York Times, very aggravating, but wonderful New York Times exploration of this issue that came out last year at Bon Secours Hospital in Virginia, where they used their nonprofit status from one hospital and in an urban underserved area, and took all the money they saved and put it into a wealthier insured area. And if those of you who've heard us talk about 340B know that when you get the drugs at a discount, you sell them to a fully insured patients and pocket that difference. And when you're selling that to them, you're selling them on average about 5 times, not 5%, 5 times the total cost. So a patient's getting a bill that's 5 times higher than what it costs that hospital to make. And for cancer drugs, that's tens of thousands of dollars sometimes. And then that could go all the way up to 11%. So 340B, hospital site neutral payments, where they're paid the same for regardless of who's giving the treatment and where. And then sort of transparency and reporting requirements. Those are all things that are on the end of year list. Well, I say end of Congress list for us this year, because we have those 2 big government funding bills coming up, and a lot of opportunity there. And Ted talked about PBMs. There's a very large bill in the Senate called the Lower Cost, More Transparency Act that includes a lot of elements around hospital transparency, hospital reporting requirements, site neutral payments, and then also a lot of the wish list on PBMs. So that is a great place to start. Now, Ted talked about that Congress is heading into a period where we're going to have sort of gridlock, and that's both because we have the sort of historically partisan time on Capitol Hill where nobody wants to work together, but we also have the elections coming up, and so things tend to stop pretty much for the rest of the year in an election year. Not much is going on because nobody wants to be seen working with each other, passing things that might help the other party. But where it's not going to stop is in the state level. The last 2 years, COA has spent a tremendous amount of time and effort getting our state policy teams up and running and getting engaged in the state level, because the fact of the matter is, when you look at the rate of an idea becoming a bill, then becoming a law, that in the state level, there's a much higher percentage opportunity that it's going to pass and become reality. Upwards of, I think, 20% of bills that are ideas that are presented and make it into bills become the law at the state level, whereas at the federal level, it's below 10% on average. So, and another thing that happens with the state level is, states, there's a term in Washington called states are laboratories of democracy. States are where a lot of these great ideas are sort of worked out and get tested and get pushed through, and then the federal government takes them up. And so the states really have become leaders on a lot of the issues that we're seeing, both around PBMs. You have last year we had a historic year in PBM legislation and regulation at the state level, introducing new transparency, prior authorization, reporting requirements, and holding them generally accountable for all of what's happening there. So states are a big place this year. We're also seeing a lot of movement on things like prescription drug affordability boards. That's an area where states are trying to get into the game of regulating drug prices. On paper, that does sound good, and it is something that we definitely support. Is figuring out how we can solve the cost crisis in cancer care sometimes. However, when you start doing this and over-regulating the system, there are a lot of unintended consequences. We have, unfortunately, built a very complicated system in our country for how drugs get into the hands of doctors and then get into the bodies of patients. And when you start having a bureaucrat in a state implementing new laws from the top down without the input of independent physicians that have to deal with that system, you're going to have things like drug shortages. You're going to have things like practices being put underwater, meaning not paid enough money for those drugs. And you're going to create a tremendous amount of problems in the system. So prescription drug affordability boards are something that we really need to go into with a lot of examination, exploration, and discussion, so we can make sure there's not a lot of those unintended consequences. Because Nationally this year, we saw historic levels of drug shortages for cancer patients. And that means that when a patient needs a treatment, they're not able to access it. And we can't let that happen. And so there's a lot of reasons for why that happens, but one of them is the increasing effort to push down to penny pricing low cost generic sterile injectables that are very expensive to produce and complicated to produce, but that are not really big big ticket items. So states are definitely a big area, and two opportunities as I wrap up. We have a lot of places. We've talked a lot about these issues, and I'm just going to give a plug to CPAN and Rose and the COA Patient Advocacy Network. We have a lot of opportunities for advocacy and engagement in all of these issues, and whatever other issues may pop up throughout the year. There's a lot of fire drills that come up. TED Talk 2023 was a very busy year. 2024 might be a little quieter as far as legislation moving, but there's certainly going to be a lot of big, election year proposals put out that will significantly impact patient care. So CPAN is a great avenue for getting engaged in that. We also have a state level training program where we really train you how to be a state level advocate and engage in your local policy efforts. And then we also are this year going to be doing a lot of Hill days, a lot of engagement on the Hill. So, good opportunity there for folks. So if you're interested, I encourage you to, stay engaged in CPAN and COA. And Rose, I think we still have time for questions as well as a discussion.
Yeah, we absolutely do. And if anyone wants to put any questions in the QA box, we're happy to answer those. So Ted and Nick, thank you. And for everyone in the audience, we hear all these, if you're not in the policy arena and you're hearing prior authorization, PBMs, 340B, Stark, the Stark law, it may sound very overwhelming, especially again for any of the patients or new advocates that might be listening or new staff members at clinics. But as Ted and Nick have both said, these are patient issues. Even when you hear physician reimbursement, and I really applaud you, Ted, for addressing that right on, because you hear it and it's very easy to say, doctors make a lot of money. It's not about doctors making a lot of money. It's about running your cancer center. Oncologists need to be paid. Drugs need to be stored. Nurses need to be paid. You need a chemo chair to sit in. So these are all patient issues. So I think it's really important that I'm glad that you brought attention to these.
Hey, Rose, go on, Nick, are you gonna?
Well, I was going to just add on, I think one of the big things that we're seeing now also is workforce issues, right? And recruiting new oncologists, right? A large portion of our cancer treatment provider workforce is nearing retirement age or has indicated that they're burned out after COVID. They're burned out dealing with all these bureaucratic issues. And the more we cut to the bone, the more, if you go to go to a specialist today, try make an appointment with a dermatologist or a gastroenterologist, you're going to be waiting 6 months for your procedure, for that meeting. And you don't want that to happen to your cancer patients. You don't want a cancer patient to be facing, a 6 month or even a month-long delay when that is growing inside of you.
Hey, what I want to say is, and I just saw a question in the chat is what I want to say is also something that is getting a lot of attention, but it's sort of taking a little backseat now, is the whole IRA and the whole idea of Medicare negotiating drug prices. That's a big issue for us. I actually testified to the Ways and Means Committee last year on this, and it's a big issue because, number one, it sounds great on paper. Oh my gosh, Medicare, the government's going to force down drug prices. But the problem is they're going to force down drug prices on drugs that have been on the market for, 9, 13 years. And basically what that's going to, we think it's going to just increase launch prices. If you're a manufacturer and you say, hey, down the road, my drug may get negotiated, you're going to increase your launch price. The other thing is that it's already had a documented effect on innovation. And in cancer care, we all depend on innovation. So that is an important factor. And, what sort of ties into this issue too, when you tie in the reimbursement side, is Nick talked about drug shortages. It's very frustrating personally to me. I testified over 12 years ago now on drug shortages. And I testified last year on drug shortages. And the problem is that we're not going to fix these drug shortages until we realize the economics behind this, as Nick said, forcing these products down to pennies. So let me just say one thing, one answer that somebody says, do you have a comment on FDA granting it reimportation from Canada? Look, the FDA granting reimportation from Canada, Florida now passing laws, they're going to import drugs. Do you really think that Canada or some other areas are going to basically allow us to take up their drugs? I mean, there's so much that has to be done there. It's so basically the way this is. And, you know, all due respect, I heard the president speak literally the other day about bringing down drug prices and the difference between, and by the way, it was just not Biden, it was when Trump was president, of comparing drug prices from the United States to other countries. Well, you tell me another country. Name one other country where there's a PBM. Name another country where there's all the middlemen or even hospitals that are marking up drugs. So this is not just a pharmaceutical issue. Yes, they have a problem with it, but basically it's a middleman issue too.
And that Canada's actually already indicated that they see this as a national security risk, and that they're going to try limit the importations. Also, let's not forget, these are only, you know, if anything, it's only oral drugs. So that's a portion of our entire healthcare system and the drug needs for what we have here. So importation is I wouldn't even call it a Band-Aid. I'd call it, you know, a tissue on an issue that they need to try deal with, and they're nowhere near there.
Yeah, and another question that brought up, Suzanne asked a question. Yeah, there are a number of, there's actually a draft bill out of the Energy and Commerce Committee. I'm very disappointed in the Energy and Commerce Committee that they have not marked up that drug shortages bill, that they have not pushed that forward. I'm upset about the Senate, that everybody's talking about drug shortages, and then they're mitigated a little bit because we get some drugs in from China, some of these drugs. But this is going to be an ongoing chronic problem because we're drying up the manufacturing base and we're simply not paying enough. I know that sounds a little counterintuitive, that we want to say bring down the price of drugs, but we're not paying enough. So yes, there are, but if I look into the crystal ball this year, I don't think they're going anywhere. We're certainly going to push. Believe me, we're behind this. Personally, I have a personal stake, COA in general, but we are, and we've done a lot of work on drug shortages. But and if you want to know what we think about them, you can look at my written testimony up on the website. You can look at our response to the Energy and Commerce Committee, to their RFI. So that's on as well too. And then, Nick, I don't know if you want to touch upon another question about this.
I mean, you know,
funding programs.
Yeah, so we have, you know, someone asked a question of any updates on the battle for alternative funding programs and specialty carve-outs. We could do a whole CPAN advocacy chat around this, and we probably will at some point. But these are programs that are being devised by insurers and PBMs to essentially get in there and further figure out how they can take control of the drug spend and make more money out of it. Alternative funding programs and look to basically suck out the money from support systems for patients who are uninsured or underinsured that pharma companies provide. Specialty carve-outs are another one where they essentially turn a patient who is fully insured and get them in the system as uninsured so they can qualify for free drug from manufacturer programs. These are scary programs because at a certain point, there is no free lunch. I like to say, in this entire world, it would be wonderful if everybody would just give away free everything, but that's not how the world works. It's not the reality of the system we have now, regardless of what we want. And so what happens is one day you're going to have a patient somewhere across the country who truly needs access to these drugs, can't afford them, and the system to support them that we've built is going to be dried up and not operating for them. And so these programs are really scary. There are a couple of court cases that are ongoing around them. One that was recently won, that was a positive one in Washington, D.C. on alternative funding programs that went in the favor of patients. And they're still sort of figuring out how to operationalize the ruling in there. And the government actually appealed. It was against the government, and the government appealed that case, which was really unfortunate to see. So, you know, there's a lot of work to be done on alternative funding payments and these specialty carve-outs. I will say, you know, there's a whole list of other issues. We could talk about the IRA. We briefly mentioned that, drug shortages, workforce issues, health equity, PDABs, white and brown bagging. I mean, we could talk about a lot of things here. It's a very busy and extensive list. What we focused on was really what's most likely to, you know, in this next month or two that we're going to be really.
Let me just say, Nick, because I know, Rose, we're up against the time, we're a couple minutes over, but let me just say, somebody asked about recent updates to the EOM. No updates. EOM, which is the Enhancing Oncology Model, which is supposedly the next generation of the OCM. Very disappointing. Only 40 practices, 40 entities, 30 of which participated in the OCM. So practices are now getting some of their data. We'll see what happens. But and CMS has talked about the idea of opening it back up to try to get others involved. But the only way they're going to get others involved is basically to pay more for it. So it's a big deal. So stay tuned. We'll have more on the EOM, but there's not really anything to update specifically per se now.
Yeah.
Thank you both. And always thank you to the audience. Ted and Nick packed a lot of information into the short time frame. They both referenced the fact that we have a lot of more detailed information on the website. So please visit the COA website.
And tell them, Rose, you know, our emails are up there. So you have a problem, just let us know.
Right. So thank you, Ted. Yes, you can definitely reach us, and we always get questions after something you didn't think about, and that's why Ted just mentioned that their emails are listed. So again, thank you for being part of this kickoff series with us. Next month, I'm excited to share that we're going to have a different topic from the policy front, and this is more on the clinical side. We're going to have Marianne Fergola, who's the Chief of Wellness Services from New York Cancer and Blood Specialists, a very large practice in New York, and they have multiple locations as well. And it's going to focus on the role that community oncology plays in supportive care. So I hope you can join us then as well. And remember, everything is on the website and our YouTube channel. Thank you, everyone. Enjoy the rest of your day.